Here we go, Zach. Welcome back for our next panel discussion on remote patient care. I hope you've had a chance to make some new connections, as well as using the platform to check in with delegates inside your network. Remote monitoring allows patients to collect data about their health and then securely communicate it back to clinicians. This method of monitoring is to assist with the reduction of admissions to local emergency departments and enable clinicians to react faster to developing issues. More than 78,000 people have benefited from this technology, and 1,200 care homes have been issued with these resources. Now, care home staff can rely on this innovation to keep track of people's vital signs and other needs for more effective treatment. So with me to discuss this topic, I'd like to welcome Dr. Jonathan Serjeant, Chief Medical Officer at Generated Health Limited, Dr. Mohammad Alajilani, Senior Teaching Fellow at the University of Warwick, and Dr. Matthew Inada-Kim, National Clinical Lead, COVID NHS at Home. Don't forget to join in with the conversation like you did with our first panel by using the Q&A function at the bottom of the screen. And please do share your thoughts on Twitter using the hashtag NHE365. So welcome to panel 2. Good morning, everybody. Nice to see everybody this morning. I'd like to kick off with you, Jonathan. And before we dig much deeper, just a very basic question for me, as well as perhaps some of members of our audience. Just can you just outline exactly what remote monitoring is and what it tends to be used for?
Yeah, sure. Okay. Thanks very much. So I'm Chief Medical Officer of Generated Health. We run a platform called Florence, which is intelligent health messaging. So taking remote monitoring and actually activating people's behaviour to be able to manage themselves. So, I mean, I've been a GP for 25 years, been through, gone from paper all the way to today. And, the best bit of technology we thought we were doing over the last 10 years was speaking to people on the telephone. So this is, I've always been there as a clinician going, wouldn't it be great just to be able to have some metrics to help me manage the risk in this conversation? So remote monitoring, is just the ability for us to take some physical metrics or mental health metrics from an individual and be able to then look at them and put that together with the clinical context that helps us be able to make really good decisions with our patients. Of course, COVID, took us away from, seeing our patients, and so we really were, had to see speak to lots of people on the telephone. But the explosion of remote monitoring has made a big difference, and it's really happened across the continuum of care. It's not just happening in primary care; it's happening in community care, mental health, and in the acute sector. And I think one of the big challenges with remote monitoring is, if we start to collect lots of information, just driving an enormous amount of information into clinical teams that haven't necessarily sourced themselves out from a process perspective to receive that information. So we can end up in a place where actually we create another backlog of information. The collection of blood pressure monitoring in primary care at the moment, sometimes it's taking 6 to 8 weeks for people just to sift through that because it's turning up in emails and in pieces of paper, and therefore it takes time for patients to understand them. What do I do with this? So I think one of the things that we're really proud of at Florence is we take this information, we play it back to the patients, and they have ongoing intelligent messaging to support them to be able to manage their own care and manage their anxiety and give them real structure. And I think the opportunity with remote monitoring as we go into the future, in terms of really understanding, from a clinical perspective, are my patients safe at home? And from a patient perspective, saying, how do I do the things that I need to do to stay well, get better, take my meds well, across the long-term condition spectrum, discharge from hospitals. We've got a massive opportunity to change care. Now, obviously, that's gone.
I think you're right, and that's a very a big and a bold statement and an exciting statement, and one which I'd like to explore later, because I think you're absolutely right. also say that for somebody who's actually monitoring her blood pressure at home at the minute, sending it to a GP. So taking advantage of remote monitoring, which is great. So I'll come back to you in a moment. I just want to bring Matt and Mohammad into the conversation. Matt, lovely to see you developed COVID remote monitoring. Can you just tell us a bit about that and the thought process behind it and the speed with which you had to work to get everything in place very, very quickly to look after people in the country? Oh, I've got no sound, Matt. Let's just see if we can.
Can you hear me now?
Oh, now we can hear you. Start again.
So yeah, although I'm a jobbing acute physician, consultant in acute medicine and working in a lot of emergency care settings is my day job. I'm the National Clinical Director for Infection, AMR and Deterioration. So with my local and national hats, it became pretty obvious soon that we were kind of missing a trick with our overall COVID strategies at the beginning of this pandemic. And COVID was like a disease like no other. So the first part of the puzzle was listening to patients and, actually, I guess, acting on the horror stories I was seeing every day clinically with patients arriving blue and unsalvageable with very low oxygen levels. And then asking the question, what could we do differently? And it was after a particularly turbulent shift where we intubated and then subsequently lost 3 patients within 60 minutes. All under the age of 60, who came in with silent hypoxia, essentially, that made us think we need to get some research going ASAP, really fast research, prove the case, and then put in effect a change. So the first step was governance and getting research alignment using COVID new rules to bring together community data, ambulance, general practice data, and then hospital outcome data together, and figure out what it is that you could detect at home that might predict who was going to live or die. And after a very quick and very aggressive piece of work, looking at, I think, an initial cohort of only 150 patients, we quickly found that oxygen saturations at home were the best predictor of who was going to live or die, independent of any other physiological or monitorable variable. So it was relatively easy because a lot of people agreed with the synopsis, the idea of that. And we quickly formed a regional, local, and then national community of practice comprising of really aggressive, dynamic clinical leads, essentially, of service as well as managerial leads coming together around this idea and project. And then pretty soon we built up a momentum over the next 3 or 4 months of addressing large parts of the country. So initially about 15%, 20%, 38%. Then we got a green light from the national side to buy national oximeters, and the great help of the personalised care team at NHS England and NHSX at the time to help pull together the funding to support teams innovating in the trenches, essentially. And then what the 200,000 oximeters we purchased at that point enabled us to do was create really rapid fire resources about how NHS frontline and patients were going to enable the empowerment of patients, the education to self-monitor, self-escalate, safety netting, and to ensure that people were able to look after themselves along the lines of what Jonathan mentioned. And we put that in pretty rapidly and then quickly spread the model from 38% of the country to 100% of the country over a period of 38 days. And then
38 days, wow. And you went international too, didn't you?
Yeah, so it's like good ideas. They just spread, don't they? And we started to get the evaluation through about the difference it was making when people were monitored using this compared to if they were not. And it became pretty obvious that more people survived when they had the monitoring, essentially. And hospital admissions were for less duration of time because we were getting to people early enough to save their lives, essentially, and prevent irrevocable damage. Less of them went to intensive care. There were less readmissions. Patients loved it. There were people came out of the woodwork to give their stories about, these were patients we would otherwise cautiously just admit, just in case. In a time of nosocomial illness and absolute bed crisis across the NHS, it's the absolute worst thing you could possibly do. So it gave us a foothold in a way forward. And the World Health Organization very kindly updated their COVID living guidance to include the strategy. And then the next country on the list really was India, because it was so up against it in terms of numbers. So this felt like a really good idea that could spread easily. So we spoke to policymakers in India and colleagues, and then India then did what we did 10 times over. So they managed a total of around 500,000 patients using this strategy, with up to 45,000 patients at any one time. And what's beautiful is actually you don't need many staff to do this. If you train people right and you have the pathways in place and the right tools in place, then this can be a staff light area if you get the model right. So a lot of the grunt work, which was producing the educational videos, YouTubes, whatever media the public lapped up, written resources translated into 14 different languages, held us in good stead, because actually that was something we could spread. And then we went on a bit of a roadshow around the rest of the world, and it went across another 18 different other countries.
Gosh,
And,
that's amazing.
It's just the power of knowledge. There's no profit in this.
No, the power of knowledge. But also, I feel like I should say a big thank you to you and your colleagues. I mean, listening to what you did and the way you just sort of say, oh yeah, a bit of a roadshow, 18 countries around the world, and the speed with which you did it, 38 days here. I mean, you saved, I'm sure, Matt, many, many lives working so quickly with your team. So massive, massive thank you. We'll come back to you in a minute. Mohammad, you can't get much better example than COVID and Matt as to how, remote technology can help in health. I think we've got very exciting times, as Jonathan alluded to, we've got very exciting times ahead in healthcare, obviously made much quicker by the pandemic. But from your point of view, what can remote technology help with?
I mean, it's like Jonathan and Matt mentioned. I mean, one of the main things is to help patients with healthcare management. So when they see their data, for example, obtained from the body sensors or mobile phone apps, etc., encourage the patients to maybe, let's say, watch their diet better, work on some exercises. So this is one of the aspects where, of course, it's very important for patients. As we always say, patient is first. And also for like clinicians and the healthcare team is where we try to make their life easier. So by implementing all the new technology, instead of for example, waiting for patients or missing their appointments. So feedback can be provided to the patients like immediately without the need to travel and save all this cost and save all the travel. And as we saw in COVID-19, the implementation of this technology was really useful because, of course, we wanted people to stay in their homes, not to interact with the community. Also, I mean, now we have, the fancy thing, the AI, artificial intelligence, and this is where the machine starts things as a human. And of course, everything is based on the data we collect from patients. So all this data will be analyzed very, very fast using the algorithms we use in the systems and the software, and then the feedback can be provided to patients immediately. And the other bit is from the clinician, from the professional side, is maybe it does help, not maybe actually, it does help with the decision making. So of course, I mean, we're human, our brains work in a specific speed, but if we provide the data and the facts to the algorithms in the AI, this could, of course, provide feedback, decisions actually, and feedback based on resources, like different resources, rather than asking the patients, for example, about what you feel now, what symptoms you have. We can retrieve data from, for example, the patient's record, from the history, clinical history or medical history, and then collect more information that one human can get at one point, and give this decision to clinicians, and the clinicians, of course, will review it and will approve it or suggest something else.
There's still, Jonathan, for me, there's still nothing like actually seeing a person. And as somebody who was in the emergency department 2 weeks ago overnight, it was really important for me to see a person and not submit information because I was so poorly. But what difference is remote monitoring making to clinical teams in terms of their workload, consultation style, managing risk, and to ensure that when people really do need that face-to-face looking after, there's the capacity to be able to give that, in-person care?
Sure. Okay. I think let's be really clear from the beginning. Yeah, technology is not going to replace the human relationship. Yeah, medicine is super important that people connect with each other and we understand people's world and what does medicine mean to them. What technology can do is supplement it and work in partnership. And if we're really careful how we design our algorithms, where you can start to create intelligent kind of algorithms on the back of remote monitoring, then we need to be really careful. We're really focused on what the problem is that we're trying to solve. So one of the things we do at Florence is when we work with practices or community trusts or acute trusts, we spend a lot of time with them saying, what is your problem in this care pathway? So particularly around hypertension, you mentioned, Helen, there's a lot of information coming in. There's a lot of duplication. Technology is super good at providing productivity efficiency if it's well implemented and the team respond to it. So we make sure that our algorithms deliver the productivity efficiency first, because that gives the clinicians the immediate feedback that this is helping them in their workload. Then what we do is we make sure that what is the clinical context that we're working with. We make sure, so for hypertension, make sure we're working to national guidance, and we're also taking any kind of good areas of innovation around, and we build that into the algorithm to ensure that when people are being messaged and spoken to, they're given really good structure to their care. If you think on average, long-term condition management, maybe they spend an hour and a half a year talking to their clinical team. That's a lot of extra time the patient has got to spend on their own working out the complexity of how to live well and manage their medicines. That's even more complex in cancer care and things like that. So what this you can then do is provide really super good structure, good feedback as the remote monitoring gets, you send it into your clinical team. The clinical team doesn't need to respond because the algorithm holds them, streams them, helps them basically helps them reduce their anxiety and gives them signposting to what to do should their monitoring threshold be dangerously out of range. What the clinician can do from the other side, because they can't only see them in a very brief period, they can look back and see how's this person been tracking over the last year. What have they been doing well? What other things have they done? They can see the conversations in the algorithms that we build. And then they can have a different type of conversation with a patient where they feel assured they're talking to the right person at the right time. Does this person need medication change now, or do they need other support? But also they're able to see when they fluctuated and find out with the patient what was going on in their life. So it gives a clinician a very different view of what a patient has been doing and experiencing. And I think that's a big difference. You've got to have a good platform to do that, and it's got to be integrated into their clinical workflow. Now, I think when you get all that stuff well done and you've got your data structured well, then the exciting stuff of the new stuff of artificial intelligence, we can start to do that in an ethically careful way, so that we make sure that we don't send artificial intelligence off into deep holes where it doesn't help us solve the problem we need to do, but actually we take this nice and slowly, because AI is very new and is particularly new in primary care, and we're currently put a bit of artificial intelligence into that, but we're really focused on the ethics behind it, and we're not going to worsen health inequalities, for example, through this, and make sure we pay attention to that.
I'm going to come back to you, Matt, in a minute. But Mohammad, did you just want to pick up on what Jonathan was saying there? Sort of the use of
exactly.
But not replacing, obviously.
I mean, definitely, I agree with Jonathan. It will not replace. I mean, this is what this is also what our students always ask, because we have clinicians as students doing courses, and are we going to be replaced? Definitely not. No, I mean, but the main idea is to help clinicians taking decisions, as I mentioned, it's from different sources, and this is the wonderful thing about it. But for example, in mental health, we use chatbots, And chatbot is like where the patient can talk to like an avatar, a robotic programmed avatar, and they can talk this indiscreet, so the data is private, anonymous, and the chatbot can analyze what the patient is saying, and of course analyze this sentences and provide feedback. So in this situation, we are not replacing the doctors or the clinicians, but we are trying to maybe to computerize or digitalize some of the tasks that could help patients if they want to talk like in private, and if they need, if the chatbot decided or that maybe the patient needs to talk to a doctor, then they will refer them to a doctor or will suggest like, please talk to your GP, talk to your doctor. But yes, so definitely it's not to replace clinicians.
Good. Matt, I've been hosting the virtual NHS conferences for a few years now, and watching, from pre-COVID times and watching the development of what's going on within the NHS and healthcare. And I certainly personally feel, having watched the transition that we are living in, very exciting times now. What conditions or pathways are you working on now?
So it's a good question. So I, like you, firmly believe in face-to-face where you need it, to be quite honest. And I worry sometimes we're running before we can walk in some of our digital endeavors. Though in my patch, we have a brilliant initiative using telemedicine to look after the health of about 650 care homes from a single comms hub, and with amazing results. You still need someone on the shop floor actually seeing the patient, touching the patient, having the proper conversation, particularly in acute deterioration. There's no substitute for that, and the tech is not there to deliver an alternative to it. So what I think we need to do is bridge the best of both worlds. Primary care needs a complete transformation. It is not working the way it was originally intended, not because general practice is lazy. It is an amazing, incredible group of professionals who have gone above and beyond for the whole of their careers. But what we need is transformation within it to divide it up better into chronic, long-term condition, complex, comorbid care. The 0.67% that take up 30% of our resources, admissions, our deaths, and our length of stay and expenditure across the NHS. That's what general practice is particularly brilliant at doing. And then separating that out from the acute care element. So there needs to be transformation of the entire structure of the NHS to begin with, followed by digital structures that support both that chronic long-term management along the lines of what Jonathan and Mohammad have mentioned in terms of that high-intensity usage, the artificial intelligence within it to predict deterioration and outcomes and metrics, to give you a benchmark as to when to intervene and what interventions work best. And then from the acute perspective, I think large-scale access for patients is the most crucial thing. It is hard for patients to see a healthcare professional in the community and out of hospital setting. And that's why they're all coming to the emergency department. And that's why our ambulance service is under such humongous pressure. So we need to turn the tap off whilst also promoting increased access, particularly in areas of deprivation, particularly in areas where there is not digital literacy, and to ensure that that particular cohort of patient have a viable alternative in the community. Once patients are seen face-to-face, then they can be dealt with in a more digital sense, a very kind digital sense that will enable the monitoring to keep them safe, and a degree of closed-loop consultations that will mean that patients are not merely dumped back in general practice with extra work for busy GPs or sent on to the hospital, but will dealt with in closed-loop episodes of care. And that's where I think digital tools will really help us. So with COVID, we found we were able to look after up to 200 or 300 patients at any one time in the community using digital tools. Basically, patients were able to text in their observations and how they were feeling, and we put that onto a RAG-rated dashboard that enabled us as clinicians to have limited numbers of staff to actually track patients and how they were doing. And what it enabled us to do was to focus on those deteriorating, not the well, not the recovering, but the people that were going off. Ideally speaking, that's what patients want. They want a system they can trust. They don't necessarily need hand-holding with phone calls every 3 times a day or 4 times a day. What they need is a system that clinicians have the time, and what digital does is signpost the urgency and the most important patients that clinicians should use their time on.
Brilliant. Thank you, Matt. I was just looking slightly distracted because I was reading a question from Matthew, which perhaps you could take, Jonathan, for me. Matthew says, do you see AI as allowing healthcare providers ultimately to redeploy staff away from such tasks as triage? He says sorry, I put my teeth back in. The deterioration index in EPIC, one of the largest EPRs, was designed with this in mind. And with staff shortages in healthcare globally, this may be a timely tool to assist overburdened staff. What do you think there, Jonathan?
Well, I don't know about the specific EPIC solution that he's mentioned, but I mean, I would go back a little bit to what I think Matt just talked about. And where can remote monitoring and AI really make a difference? And I think it's in a place where we already know the diagnosis, and that's probably a safer place to be. Because then I think the COVID wards were a good example of that, with very basic remote monitoring. But I think if you start to try to do diagnosis when a patient is unwell, then you've got a few metrics that you could basically put into a different score to basically triage people through. But that obviously is a good assistive technology, but you also need to be able to talk to people and understand their context, because different people in different environments are more at risk than others, and so therefore having that context I think is important. I think if you want to be sure about the difference you can make, I think you can make a big difference to patients with long-term conditions. I think if you want to titrate medicines, that's a really good way of doing it, and free up clinicians so they can be doing some of the more focused acute work. Giving people bite-sized education can free up kind of our for example, our nurses doing working around a long-term condition, but also giving people the ability to manage exacerbations in known diagnoses. COPD, asthma, and things like that is obvious, which reduces A&E attendances, and algorithms can help you do that. Whether we've got to the point yet where AI can help you do that, I think that's an exploration. And I again would be cautious at this point about putting AI-driven tools at the point of care without a lot of oversight and a sense of like, have we duplicated clinician view alongside it to make sure that we're making the right decisions with it.
I have 2 minutes left, so Mohammad, 1 minute for you, and then a final thought from Matt. Mohammad, one of the things we haven't talked about are barriers to implementing this technology in healthcare. Without ending on a down note, what are the barriers that we have to overcome? And if you keep it to a minute, then I won't get into bother.
Yeah, I'll be very quick. I think some of the main barriers. First, it's the resistance and lack of awareness from people who are not aware about the benefits they can get from the implementation of this technology. And sometimes this can be on maybe a decision-making or decision makers levels. So this will, of course, impede the introduction of this technology in different organizations. The other option is, because of this resistance, maybe the cost would be another barrier, because if I'm not aware of the benefits I can get, so maybe I will not easily find funds to implement these projects. Also is the lack of study and analysis before implementing these studies. So technology is amazing and hopefully it will save a lot and everything, but there have to be a proper analysis study before implementing it. So implementing a certain type of technology, let's say telemedicine or telemonitoring, does not mean that we solve all the problems. So like Jonathan said, we need to know what the problem is, and then we can implement, or we can decide about the technology that could help in this situation.
Oh, thanks, Panda. I am going to wrap you there because I will get into trouble. Just a final thought from Matt. Matt, Jane says that she agrees with you about the need for face-to-face access, especially with acute episodes of care or exacerbations of LTCs. Is there an added benefit of digital and near patient testing, monitoring of patient empowerment, as Helen is feeling now?
Yeah, you need both. And there are interesting tech advances I've seen across the world that involve remote examination strategies. So, linked to either smartphones or other equipment, which might have some merit, I guess. But, there is something really special about picking up on someone's pulse, touching someone's skin, that it's really difficult to, I guess, substitute. So I'm on Jonathan's side here. I just worry when you've got potentially critically ill patients, and the fact that good though our tech is. You see, no one's going to go with tech if we promise the earth here. What we need is to bring people along within the comfort zones of our evidence, our validation, and our personal experience. It has to have value added for us to get anywhere with change across the NHS, and that has to be through robust research and evaluation. And
hopefully complement what the NHS has been so good at over all these years, which is that face-to-face care. I am out of time, gentlemen, much as I'd love to continue this discussion. I hope you'll join us for another of these events. You've been smashing. It's been another great conversation. So my thanks to Jonathan, Mohammad and Matt. And thanks to you, our audience, as well, for providing some insightful questions and thoughts. Next up, we have another keynote for you. Breed O'Brien, the Director of Innovation and Digital Health for NHS England. Breed is the Director of Innovation and Digital Health in the National Digital Care Models team within the NHSE Transformation Directorate. She leads a national programme of work focused on technology to support people at home and improving patient pathways using technology. She has extensive improvement and digital transformation experience, supported by a clinical and operational management background in acute care within the UK and Australia. She's especially interested in the people, process, and how technology can enable true partnerships with those across the health and care sector. So over to you.
Thank you. Good morning, everyone, and I hope you've enjoyed the morning so far. I'm Breed O'Brien. I'm the Director of Innovation and Digital Health and the Transformation Director, as my colleague has just said. And I'm delighted to be here today to speak to you about what I think is a really important topic. I'm a nurse by background, and I moved into operational management in Australia. And I've been privileged to spend the last 20 years of my career in England consciously moving between technology and improvement roles and across system and provider roles. And wearing those different hats over the years, often the only thing that's changed for me is my title, the name, because actually digital and improvement are so intertwined, they're inseparable for me. So I'm going to talk to you from that context today. And as in many aspects of our lives now, I can't think of an improvement use case in health or care that wouldn't involve technology, or indeed a successful technology implementation that hasn't had improvement thinking behind it. And I wouldn't disagree with anything colleagues have just said on the previous panel. Of course, technology is not for everyone, and we need to be cautious that it is used to best benefit on an individualized patient level. So for me, technology is absolutely about people, process, and technology, and in that order. And I actually became involved in technology in 2001 as a nurse. So I can tell you it was an extremely lonely place. I'm delighted to say from the social media coverage from the summer school last week, there's a huge change. So we've got a really vibrant clinical nurse information officer group. We've got great clinical chief information officers, and we've got a really growing community of AHPs in this space. So I feel we're in a really positive place to move in the right direction for technology-enabled care, because we've got good, strong clinical leadership. And as per the previous panel, that is absolutely vital. So we're in the right place, I think, to capitalise on it. We also, our general clinical workforce, I'm delighted to say, are much more tech savvy than they were in 2001, but that needs ongoing support, and it is a key national focus. But most importantly for me, COVID, and I think that's just been mentioned as well, it's changed public expectation of how they can and should be enabled to engage with healthcare in a way that's never happened before. So we have a very important moment. So we can go to the next slide, please. Whilst lots of the focus for technology is on levelling up and ensuring every organisation has an electronic patient record, and that is absolutely as it should be, because that is a baseline that's really important. It's also important that we look at how we can support patients in their own homes. In due course, EPRs may support that, and somebody mentioned EPIC on the last panel, but it can also involve the use of remote monitoring platforms to enable people to submit their data through connected or disconnected devices. We obviously must address interoperability in this model to ensure any data that's collected can be shared by any clinical team looking after the people at home. And for me, a key point is that the person or their carer is absolutely involved in their care in a way that can enable them to be more confident with self-care. This is the potential to move us from what's been a traditionally paternalistic model of care to real partnerships with people. And I'm going to speak today about our programme of work, which is unsurprisingly called Supporting People at Home. And we basically support many national initiatives such as the NHS at Home programme and some of the work that Matt spoke to about that on the last panel, and our national virtual ward programme, which I'm sure Tim will refer to in the next panel. Interestingly, when I was invited to speak to this keynote, I didn't realise what the panels were either side, but we're perfectly placed between the panel we've just had and one focusing on virtual wards, as it reflects the focus of our work. So we can go to the next slide, please. So our regional scale programme is a centrally funded, locally driven initiative. We identify themes for focus nationally, and local systems then determine what technology issues they would like to scale locally within those themes. And you can see on the slide the themes that we've been working on this year. We also rapidly support rapid sharing of learning across the country on this work through our Innovation Collaborative, which I'll come to later. We work with national colleagues on programmes that range from proactive sort of primary community care-led prevention models, like our blood pressure at home programme, through to the more reactive acute community models, such as virtual wards, and then everything in between that supports people at home. The essential factor is that we're using technology to measure parameters such as vital signs, symptoms, PROMs in the person's own home. And that, of course, could mean that the same technology is used for long-term condition management and for acute level care, but the workforce and the intensity of the interaction will differ. And like Matt said, this is not saying it's only technology. There'll be blended models of complete tech-enabled service that's delivered virtually through to all face-to-face, and then blended models in between. And it's important to know that all of our work includes the 400,000 people in England for whom home is a care home. As you can see on the slide, in fact, this slide is slightly out of date. I can say that as of now, we have supported 370,000 people across the country in their own homes. And for 22-23, we're continuing the 4 themes from last year, but perhaps with different areas of focus. And they're the ones that are actually on the screen. So we can go to the next slide, please. This is just a little overview of our Innovation Collaborative, which is our learning system. And all of our work is supported through this. It's a vibrant learning community where people share challenges, because that's just as important as the successes. And we provide lots of resources on the NHS Future site and through our playbooks. And there's a couple of QR codes on there, but I will leave a slide at the end that's got the link for anyone who would like to join that. But I'm now going to ask my technology colleagues to play a short BBC clip from last year, just to give you a sense of what I'm talking about. So if we can play that film, please.
It was the middle of October at 3 in the morning when Carol Whitlock anxiously waved at her husband as he was conveyed to hospital with COVID.
I remember one consultant getting down by the side of the bed and just simply saying, "You've got to fight this."
3 weeks later, instead of staying in a ward, he's continuing treatment at home. An armband monitors vital signs, sending information to nurses. David gets twice daily calls.
I feel quite bright this morning.
Oh, all of your observations are looking really good my end. Have you been checking them yourself with your pulse oximeter?
The last time, about an hour and a half ago, it was about 94.
At home in the virtual ward, he was hooked up to oxygen for 5 days.
When he first phoned me to say, would I be able to pick him up when everything was arranged, I was a bit surprised, I guess. And am I going to cope? Is it going to be all right having him at home? Will he get the support that he needs? Will it all be down to me? But actually, as it progressed, all my fears were allayed.
It was another step that you sort of thought, oh, you know, moving out of the security of the hospital. But the more I thought about it, the more I like the idea. You know, the hospital is brilliant, but it's not like being home, is it?
So you can see from that, David is obviously someone who would otherwise have been in a hospital bed, and that is the key focus of our national virtual wards program. We can just pop to the next slide. This is a program of work that is being led by the National Community Health Team, and my team support the technology enablement. So it's really important that we provide a model that can provide face-to-face care, but also we know now that technology can play a significant and vital part of augmenting that care. And for some people, it might avoid the need for face-to-face care at all, as shown in the film. But as Matt said, we need to continue evaluating and researching this. But we're also hearing from patients that the use of technology makes them feel safe. The knowledge that someone is keeping an eye on them in the background is really important to them. It's never going to be and must never become a one-size-fits-all model, but it's important we offer technology-enabled care to all patients rather than have our bias determine who it's offered to, because we all have our personal bias. But the decision about who it's right for is then an individual decision between the patient and the clinician. And for some people, face-to-face care will remain the optimum choice. So you can see from that slide, we've got quite a significant ambition, 40 to 50 virtual ward beds per 100,000 population. And I'm delighted to say that actually all ICSs across the country are now planning how they'll deliver this much needed capacity within their local system. And we're looking to support them as much as possible in that. So we can go to the next slide, please. So I just want to, on here, this is a picture of a tweet that a patient who, Steve, has had a deep vein thrombosis many years ago, and then was on anticoagulants, and then suffered a stroke. So he, as he describes it, he has very sticky blood, and he needed to be on intensive monitoring, so weekly blood tests and adjustment of his anticoagulation. But he does this now using technology from his own home. Previously, he'd have to drive to hospital once a week. This was him tweeting to say it enables him to now have holidays and stay within the therapeutic range by using the technology and being able to liaise with his clinical team. To quote him, he now controls his illness rather than it controlling him. So it's really important for him. If we can go to the next slide, please. I mentioned our blood pressure at home program. 137,000 people die every year from cardiovascular disease, and measuring blood pressure and managing hypertension could have a significant impact on that number. I'm not going to speak to the data on the slide, but as you can see, there's a significant opportunity if we actually manage hypertension to prevent cardiac disease and strokes, which are obviously very debilitating for individual patients and very costly. So this is a really important initiative that we are focusing on. Next slide, please. We also work, I should say that our work with annual physical health checks for people living with a serious mental illness is to enable earlier detection of physical health issues in this group of people. There's a 20-year life expectancy variation for people living with an SMI that relates to physical illness. So as you can tell from early detection and then using some of the work we're doing on long-term condition management, we could really make a big impact for this group of people. And lastly, I wanted to spend a few moments on our work with care homes, and if we have time, I will play the video. This is cast your minds back to COVID time and how vulnerable this group of people were during COVID. Ensuring we could still monitor care home residents' health and wellbeing was a key driver for us. And independently, all 7 regions choose to work on this theme with us. We now have examples from across the country where care home staff are regularly checking residents' vital signs, and this enables them to calculate the National Early Warning Score, which they can then have a better conversation with GPs or healthcare professionals about what's right for that person. And very often that might be to keep them in the care home, because you can imagine moving vulnerable people to an A&E department, to an unfamiliar hospital environment, is not always the best thing. And we're now seeing reduction in the number of people conveyed by ambulance from care homes, which for me is a really important thing. But I would like, my final point would be, this is not just about the technology, it's about people, process and technology working together. And that's why the alignment of improvement thinking and digital are so important in all we do. I'm not sure if I have time to play the film, but I'm sure the slides can be shared later. But this is Paul's story and what it means for him as a care home resident. So if we go, the next slide then is just all the links. Do get involved, do join our Innovation Collaborative. And thank you for listening, and I hope you enjoy the rest of the day.
Breed, thank you very much. You really brought your presentation to life, I thought, there with your real life, particularly with the film you showed. Hopefully we can find some way of showing your second film, perhaps on the platform somewhere, giving people access to it. It really was a brilliant presentation, Breed. Thank you very much. And I'm sure that our audience found it incredibly useful and will take the information and use it to build a brighter future for healthcare in this country. So time now to take another 10-minute break. Do use this opportunity to network with your fellow participants and refresh, and we'll see you back at, let me look at the clock now, 11:35, exactly 10 minutes.